Good afternoon, everyone. My name is Dr. Anireto Chika, and I'll be talking today about principles of cognitive behavioral therapy. The objective of this lecture is for us to have a broad understanding of cognitive behavioral therapy, especially its principles. I'll be using this outline and talk about the introduced, and I'll talk about what psychotherapy is, what cognitive behavioral therapy is, give a brief history, talk about the evidence supporting CBT, talk about the principles of cognitive behavioral therapy, the structure of CBT, and the illnesses that can be treated with CBT. Then I'll conclude. So by way of introduction, why would we family physicians be talking about cognitive behavioral therapy? Well, it's because we are primary care physicians, and in the course of our duties as first contact doctors, we see and take care of a myriad of undifferentiated patients with both biomedical and psychosocial problems. So this could be exhilarating and also a challenge. So what I've shown here, if you can see my cursor, is intertwining rings. This shows the nature of the biopsychosocial model and the type of care we family physicians aim to give. So psychotherapeutic skills, having those kind of skills is crucial in primary care because it can help us to tease apart psychological from psychiatric disorders. So a lot of times we see physical illnesses masquerading as psychological ones in the primary care setting and vice versa. So having some knowledge of psychotherapeutic skills, especially cognitive behavioral therapy, is helpful in this regard. But what is psychotherapy? It's a broad umbrella term. It's defined by Professor John Narcos, who is a clinical psychologist, and he defined psychotherapy as the informed and intentional application of clinical methods and interpersonal stances derived from established psychological principles for the purpose of assisting people to modify their cognitions, that is, their thoughts, their emotions, the way they feel, their behaviors, and what they do, and or other personal characteristics in the direction that the participants themselves deem desirable, that is, in accordance with the goal the patients have. So psychotherapy is such a wide umbrella of different types of techniques. Some are minor variations, while others can stand alone on their own. Examples of different psychotherapeutic modalities include psychoanalytic or psychodynamic therapy, founded by Sigmund Freud, and this posits that people's unconscious drives and desires have an effect on their present difficulties. So the psychodynamic therapist would aim to dig deep and uncover the unconscious motives that people have, and in so doing, help them to work out or work through their present difficulties. Humanistic therapy has its emphasis on the free will, on self-actualization, and helping the individual to become the best self that he or she can be. Behavioral therapy uses operant and classical conditioning to help patients to reinforce good behaviors, reduce negative behaviors, especially used in the treatment of phobias. Emotion-focused therapy helps patients to identify, accept, refocus, channel, and change their emotions. While cognitive behavioral therapy, which will be the focus for today's discussion, combines cognitive and behavioral techniques to help patients deal with their difficult problems. There are different ways to deliver psychotherapy. It could be done on a one-on-one basis, or it could be done in groups. It could even be done in families, or it could be done with a couple. That's couples therapy. So cognitive behavioral therapy is a type of psychotherapeutic modality that's based on something called the cognitive model. So it was developed by a psychiatrist, late Professor Aaron T. Beck, of blessed memory, who passed on last year. So rest in peace. Cognitive behavioral therapy is actually a combination of two approaches, and it was combined in the 1960s. This is the professor, the late Professor Aaron Beck. I hope you can see my cursor. The elderly gentleman is in a wheelchair, and on his left is his daughter, Judith Beck, and then on his right is a facilitator, and I hope you can see me there with my colleagues. This was in 2018. A brief history. So cognitive behavioral therapy was derived from the amalgamation of the cognitive and behavioral therapies. This was in 1967. late Professor Aaron Beck, he was trained in psychoanalysis, actually a psychiatrist by training, discovered that his patients got better when he was able to identify their spontaneous thoughts, which he called automatic thoughts, because they came about without them having, the patients themselves having anything to do with it. The patients had thoughts that just popped into their minds. And so he called them automatic thoughts. He realized that by modifying these thoughts and making them more realistic, the patient's emotions, difficult emotions, were relieved. Cognitive behavioral therapy, therefore, is based on the cognitive model, and it posits that someone's emotions and physiological reactions depend on the automatic thoughts, not the actual situation itself. The thoughts themselves come about as a result of what is called core beliefs. A core belief is the basic way an individual sees themselves, other people, and the world. The core belief might be something like, I am vulnerable, I am trash, I am not good enough. They are judgmental of me, the world is difficult, the world is dangerous. Rules such as I should work very hard, I should always do my best is an intermediate belief. An attitude is like, an example of such is something like, it's terrible not to do your best. An assumption would be, if I don't do my best, I would never amount to anything. Then the automatic thoughts come about as a result of both the core beliefs and the intermediate beliefs, and they are the ones that determine one's emotion. So if you want to adjust or modify someone's emotion, you would look at their thoughts. And the source of these automatic thoughts are the core beliefs. This is an example of the cognitive model I've been talking about, posited or derived from Professor, probably made this a mistake, late Professor Aaron Beck in 1967. So the physiological reactions, for instance, palpitations or sweaty hands, and the behavior, flight or freeze, and the emotions, anxiety or sadness come about as a result of the thoughts that an individual has in response to the situation, not the situation itself. So two people could come into the same situation and have different emotions if they have different thoughts or perspectives about that same situation. As I'm giving this lecture, if I had the thought that the people listening to me are bored, they don't understand what I'm saying, I might have the emotion of being demotivated and a bit upset. But if I had the thoughts in the same situation, giving the lecture, and I felt you're listening, you're understanding, people are geared towards understanding, they're excited about what I'm saying, then I might be motivated. I might be, excited to give a lecture. So the same situation, I'm giving a lecture, different thoughts would give rise to different emotions. So this is another example. This is an example I use when I deliver the lecture on stress management. So imagine the same situation at the place of work. The situation is increased workload, more patients, for instance, maybe during the bomb blast, when patients increase in the hospital. So situation one and situation two is the same. And then one person, let's say person A, had the thought, these people want to kill me, so many patients, and had the emotion of anger or anxiety, and then had increased muscle tension, sweating. And his behavior was to become distracted and feel even more stressed. While in situation two, the patient or individual B, oh dear, sorry, I moved that. So individual B had another thought and therefore had another emotion and felt less stress. Sorry for that. So what is the evidence? How much backing or evidence-based is cognitive behavioral therapy? So the truth is there is absolutely overwhelming evidence in favor of cognitive behavioral therapy as a treatment of choice or adjunctive treatment for a vast array of psychiatric and medical disorders. For depression, for instance, evidence has it that cognitive behavioral therapy is equivalent to antidepressant medication in the treatment of mild and moderate depression. In the treatment of severe depression, evidence has shown that a combination of cognitive behavioral therapy and medication is more effective than either treatment alone. the advantage that cognitive behavioral therapy has over medication is that patients who are treated with cognitive behavioral therapy are less likely to relapse than patients who are treated with medication. And this is because patients who are treated with cognitive behavioral therapy actually learn coping skills to deal with their difficulties versus patients who are treated with medications, in whom perhaps once the medication is tapered off, the difficulty resurfaces and the emotion resurfaces as well. For anxiety disorder, different types of anxiety disorders, panic disorder, for instance, cognitive behavioral therapy is actually the treatment of choice for panic disorder. Cognitive behavioral therapy is effective in the treatment of not only panic disorder, but other anxiety disorders such as post-traumatic stress disorder, obsessive compulsive disorder, even treatment of specific phobias, generalized anxiety disorder, for instance. Other than mental illness, like the depression that we've mentioned, cognitive behavioral therapy is useful in the treatment of any medical condition, so long as it has an underlying psychological aspect. For instance, cognitive behavioral therapy can be used in the treatment of obesity. How, you would probably wonder? Well, it's because those who overeat are emotional eaters. They have a dysfunctional relationship with food. People who are obese tend to have the idea or the belief that food, for instance, might be the only thing that makes them happy. When I eat, I'm happy. When I eat, I'm not stressed. So cognitive behavioral therapy helps in this regard by helping the patients modify these beliefs, and in this way reduces their tendency to overeat and helps them to actually lose weight. In substance abuse, patients attach different meanings to their medications. They're called addictive beliefs. Addictive beliefs, positive outcome expectancy, where patients believe, for instance, that I cannot survive without alcohol. I am a better person when I drink, for instance. I cannot cope without codeine or without pentazocine, for instance. So cognitive behavioral therapy helps in the adjunctive treatment of substance abuse, in addition to rehabilitation, of course, by helping the patients deal with these beliefs. So by undermining these beliefs and making them less powerful, less dominant, patients are able to deal with their urges and their cravings, and therefore, in addition with rehabilitation, overcome their addiction. In chronic pain, CBT is effective because it's been proven that rather than just respond to pain, our brains can actually modulate the amount of pain we feel, depending on the meanings that we have, depending on the meaning the patient gives to the pain. For instance, a soldier who is involved in battle and has an injury or an amputation, and then having to have that injury would mean they're going home and leaving the battle, would feel, this is evidence-based, factual, would feel less intense pain than someone who the meaning of the pain would mean something, less beneficial. So the meaning the person gives the pain affects the intensity of the pain. This is what is called the gateway theory or the neural matrix theory. CBT also helps in the treatment of insomnia. Principles of cognitive behavioral therapy. There are 5 basic principles of CBT. They are the therapeutic alliance, collaborative empiricism, cognitive conceptualization of structure, and empowering the patient to be their own therapist. The therapeutic alliance is a cornerstone of every CBT session. It's very important for a patient to feel safe with you as a therapist, because you're going to be uncovering and unearthing very personal and potentially painful and difficult problems in the patient's life. So the patient needs to have a relationship or an alliance with you in which they feel safe. There are different aspects or components of this therapeutic alliance. The first is an empathy. One of the ways to strengthen the therapeutic alliance between yourself and your patient as a therapist is to practice thought empathy. And thought empathy means identifying a thought, especially a negative one, and validating a patient. For instance, a patient might say something like, nothing would work. I'm just here because my mother told me to come, and I've been depressed for so many years. So if you were to empathize that, with that thought, you would say something like, well, it's understandable, being that you've been in therapy for so long. I get why you would find it difficult to believe that there is hope. Just saying that is validating a patient and is strengthening the therapeutic relationship because it shows empathy. Emotion empathy is where you would identify and name the emotion the patient has and inquire about it. For instance, a patient who's usually upbeat or talkative comes to a session and he's quiet and withdrawn. And you'd say, if you wanted to empathize with his emotion, you'd say, you don't look yourself today. I wonder what might be going on. What are you thinking? What's going on in your mind? So doing that is to empathize emotionally. Another component of the therapeutic alliance or the therapeutic relationship is unconditional positive regard. A therapist must never come across as judgmental towards the patient. We should always view the things they tell us, even if they are against our own moral beliefs or religious beliefs, from an aspect of curiosity and not of one of judgment. So for instance, a patient might tell you, I've had 3 abortions and I even had to have my womb removed, but my husband doesn't know and he thinks I'm infertile and I really don't know what to do and I'm having sleepless nights. So it's not your place as a therapist to say, how could you do that? I can't believe that, or even show some kind of shock, your facial expression. Your place is, remember, you're a partner. We'll talk later about collaborative empiricism. You're partnering with the patient to help him overcome his or her difficulties. So you come from a place of curiosity and say, what are your concerns? What is it that's really, are you really worried about telling your husband, and what do you think are some of the outcomes of this line of action? That is how you would approach it versus judgment. Why did you do that? That is wrong. Authenticity is another component of the therapeutic alliance. So this means being a genuine, kind person and being able to share power with the patient, remembering that the patient is an expert in their own difficulties, though you may be the expert in CBT. Accurate understanding, when you understand the patient issues, when you summarize and paraphrase and use open-ended questions, it conveys the impression that you understand and gives hope that you're going to be able to help because you understand. Other components is a good positive body language, being able to show your concern through the position of your body, sitting with arms open rather than crossing your hands, refraining from checking the time, looking at your wristwatch, looking at the door, for instance, or frowning. So to convey the unconditional positive regard, we need to, as therapists, you need to remember that your body language, your nonverbal communication can speak so much louder than actually your verbal. Giving positive reinforcements is another way to strengthen the therapeutic relationship. So when you review an action plan, for example, an action plan is a homework or something that you give the patient to work on at the end of every session that would mean that they're working towards their goals. So in giving positive reinforcement, for instance, a patient comes the next session and doesn't do the action plan. So you don't want to give negative reinforcement. You'd want to say, well, okay, so what happened? Why were you not able to carry out the action plan? And the patient will give you an example or give you the reason. And then you'd say, well, I thank you for coming for today's session, and I thank you for being honest about your difficulties. Perhaps we could talk about ways in which you could overcome this obstacle in future. And then when they do overcome the obstacle subsequently, you would say, oh, well done. I mean, you did a good job doing the action plan. So that well done versus not condemning or discouraging is the positive reinforcement, being transparent. That strengthens the therapeutic alliance because it helps the patient understand everything that you're doing. Remember that part of one of the principles is to make a patient his own therapist. So the more open you are about what you're doing as a therapist and teaching the technique that you're doing to the patient or you're practicing to the patient, strengthens the therapeutic relationship. Being flexible. So cognitive behavioral therapy is a flexible therapeutic modality. It's not cast in stone. Just the way when you're taking a history, for instance, if you realize that the past medical history is crucial, you might want to, focus straight on the past medical history right away in the beginning of the medical consultation. In the same way, during therapy, Though it has a structure, there are things you ought to do at the beginning of the session, in the middle of the session, at the end of the session. Depending on the patient's specific difficulties, you can be flexible. For instance, I had a patient who, in the course of doing the therapy session, I asked patients to write down important points, and I have them summarize these points so that they could remember and read them, before the subsequent session. So I had a patient say, it makes me feel like I'm in school again. It makes me feel like I'm a student and they didn't really like school. So we had to find an alternative, and the patient ended up recording the sessions instead. So therapists are actually need to be creative in the way we apply cognitive behavioral therapy to our individual patients. Collaboration and conceptualization, very important principles. Collaborative empiricism means, the collaborative in it means that you and the patient work together to help the patient overcome his difficulties, to help the patient to deal with his emotions by identifying his automatic thoughts and evaluating them, finding out how realistic they are in such a way to help, and in so doing help the patient. So the collaborative nature is such that we don't assume that we know everything. We assume, yes, we are the experts in the therapy, but the patient is an expert in himself. So whatever understanding you have, which is a cognitive conceptualization, you run it by the patient. You say it as a hypothesis and then confirm when the patient says, oh yes, that's exactly how I feel. Empiricism means that the ideas, the beliefs, the thoughts the patient has are seen as ideas, are seen as hypotheses, which are open to be tested and not seen as facts. If you see them as facts, then you're going to be drawn into the patient's difficulties and you might end up depressed yourself if your patient has depression. And that's not helpful. And that is not even the principle of CBT. Cognitive conceptualization is your understanding of the patient's difficulties. No two patients have the same cognitive conceptualization, though they might have identical diagnosis. So cognitive conceptualization is your roadmap. It's what you understand, how the patient's difficulties came about. It's actually drawn on a diagram called the CCD, otherwise known as the Cognitive Conceptualization Diagram. So it's a sheet where you write in the patient's core beliefs, his intermediate beliefs, his assumptions, his rules, his behaviors, his emotions, his automatic thoughts, his coping strategies. So this is your roadmap, and understanding this, using this template of understanding that you have about this patient, you can use that to plan treatment and to discover or identify the therapeutic techniques that will be useful for your particular patient. The structure of a therapy session. A therapy session has a structure. Contrary to what a lot of people think, the therapy is not just where someone unburdens themselves and tells the therapist all their problems. Similar to a medical consultation where you have a physical examination, a history exam, investigations, and a follow-up. Therapy session also has a similar structure. The first CBT session is called an evaluation. During an evaluation, a history is taken. The point of an evaluation is for you to understand the patient's difficulty. So you'll be doing a lot of asking questions and putting the questions in the therapeutic model, the answers to the questions in the therapeutic model. For instance, complaint would be, I have low mood. So when did you notice this? How long ago? So that's the situation, what was happening? And then the patient gives you a specific example, and then you would ask something like, what was going on in your mind? What were you thinking? And then you'd say, what were your emotions? How were you feeling? That's for the emotions. And then what did you do? That's for the behavior. So the first CBT session is an evaluation. You take a history, you actually do a physical examination. The advantage I have is that I've been a family physician as well. I can actually do the examination myself and request for medical investigations to tease apart physical from psychological difficulties, or even identify when both might be present. Therapists who are just psychologists, or only psychologists, or who are social workers, for instance, might need to refer their patients to see a doctor for that evaluation. After an evaluation, assessment forms are given. The Beck's depression inventory, for instance, the Beck's anxiety inventory, hopelessness scale, the PTSD forms. All these are to give you an objective assessment of what the patient's difficulties might be, which would confirm your own understanding that you got from your history. So subsequent sessions after that first evaluation session share a similar structure. They all have a beginning, they have a middle, and an end. At the beginning of every CBT session, the second session downwards, you do a mood or a medication check. You'd ask the patient, how are you feeling today? How are things with you? How are you feeling in terms of sadness? I actually ask patients to rate their level of sadness or anxiety or hopelessness on a scale from 0 to 10. 10 being the most sad they've ever been in their life, and 0 being no sadness at all. So that gives you a sense of progression, how well the patient is doing from one session to the other. For children, you could use a smiley face or a face with different expressions. For those who are not comfortable using numbers or an adult, you could actually ask them, how do you feel today compared to last time? The same, are you better or are you a bit worse? For those patients on medications, I would ask, did you take your medication? How often did you take it? Then having done that, you'd obtain an update. How has it been since the last time I saw you? Were you able to do some of the action plans? Action plans, that is like the things, I said the homework, the things that the patient will do between sessions to make sure that they're working in accordance to their goals. Then towards the ending of the beginning of the session, you would set an agenda. Agenda are the things that you'd like to work on, the issues of the patient's life that need to be worked on in session. Having set an agenda, so that's collaborative again. So you'd have your agenda and the patient would have his or her agenda. And then at the end of the day, you prioritize, you ask the patient, which one of these items would you feel, if we worked on them today, would make you feel like you're working towards your goals? At the middle of the session, having identified and prioritized an agenda, you work on a specific problem. You teach cognitive behavioral skills. Remember that you're also aiming to make the patient their own therapist. Then you would follow up with discussions with relevant collaboratively set action plans, and then you work on the next problem. Typically, every session, in the middle of every session, every CBT session, you only have time to work on one agenda topic at most, because the entire session lasts for 1 hour. So you're aiming at 40 minutes per agenda item. So typically you have time for just one agenda item, or sometimes 1.5, or rarely 2 problems. At the end of the session, you would provide a summary. You would provide it yourself, or you would ask the patient, ask the question like, what would you say would be the gist of what we've been discussing about? What did you learn? What would you come away with at the end of today's session? Then you'd review a new action plan. So having collaboratively identified things that the patient could do between the end of this session and the beginning of the next session, then you would ask how, you want to make sure you don't give the patient too difficult an assignment, especially in depressed patient. You would ask the patient, how likely are you to do this? And if the patient gives you anything from 70% and above, then you know that it's likely the patient will actually do that. If a patient gives you 30 or 50%, then you want to ask, what do you think might be the potential obstacles that will prevent you from doing this action plan? So you would address these obstacles either by problem solving or by looking at the thoughts that they might have about the action plan. So your aim is to set an action plan that the patient collaborated in setting to ensure that the chances of it being done are very high. Finally, you would elicit feedback. Feedback is, you can ask a question like, so how was today's session for you? Is there anything you wish I did differently? Is there anything you wish I understood? Is there anything you wish you were hoping or you'd wanted to tell me that you didn't quite get around to telling me? So doing this enables you to tailor cognitive behavioral therapy to your individual patients. Illnesses that can be treated with cognitive behavioral therapy. So cognitive behavioral therapy can be used as the main or adjunctive treatment for any illness that has a psychological component. So things like biomedical, psychiatric, or psychosocial conditions are definitely amenable to treatment using cognitive behavioral therapy. Medical conditions such as insomnia, chronic pain, obesity, chronic diseases, and even stroke are amenable to cognitive behavioral therapy. So in chronic diseases like hypertension, the goal of CBT would be to improve medication adherence. I remember a patient of mine who had hypothyroidism referred by her endocrinologist to see me because her hypothyroidism made her forgetful and she wasn't remembering to take her medication. Other than that, she saw her medications as enemies and just felt like it was one more thing to do, which she didn't really want to do as a young patient, 19 years old. So the aim of therapy for her was to help her to see her medications like her allies rather than working against her, making her life difficult. So in this way, cognitive behavioral therapy would help in chronic diseases like that. For obesity, obesity is caused when people have a dysfunctional relationship with food, where they feel they use food to meet their emotional needs. So a patient could have ideas about food such as, I can only be happy when I eat, and eating food makes me happy, and food is the only thing that makes me happy. Patients like that. So it would be so difficult to treat this patient's obesity if you don't address the meaning they have and uncouple that using cognitive behavioral therapy. Patients with chronic pain, CBT has been shown to help reduce chronic pain. How? Because it's been shown through what is called the gateway theory, otherwise known as a neurometrics theory, that the meaning a patient has, meaning a patient gives to his or her pain, actually can influence the amount or intensity of pain that they feel. So the brain not only just responds to pain, the brain can actually modulate how much pain patients feel. So in insomnia, using cognitive behavioral therapy is used to help teach patients basically psychoeducation, for example, sleep hygiene, and also to help them to remove some of the meanings they have or some of the difficulties that prevent them from sleeping. For instance, patients with anxiety, for instance, because they are having catastrophizing thoughts, that is thinking the worst case scenarios and are able to sleep. So addressing those catastrophic thoughts, which are examples of automatic thoughts, will help the patient sleep. In patients with stroke, it would also be to help ensure medication adherence. Psychiatric illnesses like depression, suicidality. In suicidality, the aim would be to question why suicide. Patients who commit suicide do that because they see it as an escape. So in CBT, addressing suicide, you would do that by asking the patients why suicide. And what is the advantage of ending your life versus living, and then you try to create an ambivalence and increase their reasons for living. The CBT is also useful in the treatment of PTSD, somatization disorders, and panic disorders. These are other difficulties and illnesses that are treated by cognitive behavioral therapy. So in conclusion, cognitive behavioral therapy is definitely the most widely researched psychotherapeutic modalities, and it is useful in the treatment of a vast array of illnesses frequently encountered by family physicians. So a sound knowledge of the theory and practice of CBT will help alleviate the suffering of the teeming masses that we family doctors frequently encounter. Thank you, and these are my references.